Hi, greetings from the Monahan Control Center. Um, Today we're going to talk about uh, gestational hypertension. You can find the information that we're going to cover in the complicated pregnancy PowerPoint, which is filed under week 7 on your Moodle account. Um, we'll cover some of the other complications in class next week, those being things like bleeding in pregnancy, hyperemesis gravidarum, preterm labor, premature rupture of the membranes, multiple fetuses, twins, triplets, multiples, gestational diabetes, um, poly and oligohydramnios, uh, those kinds of things we'll cover in class next week. But for the purpose of this online lecture, we're going to focus primarily on those hypertensive disorders that can arise during pregnancy. And again, the slides that we're going to cover in this segment, you'll find slide number 22, going through slide number 29. So when we talk about hypertension in pregnancy, um, a few things that you sort of historically, just to give you some background, because this lecture, if I did it 30 years ago, would be quite different. Um, we still don't have definitively an understanding as to what causes hypertension in pregnancy, this condition that we see in some women as their pregnancy progresses. We have a better understanding of it now in 2018, and that is that one of the things that seems to be constant or measurable is that in some women they experience this excessive sequelae or phenomena of vasospasm. Um, and really, the vasospasm is a response to the pregnancy itself, meaning that it wasn't any underlying pathophysiology, that there was disease present. We know there's risk factors. So we know that people who have underlying diseases that, or their age, that can prevent them from being optimally well, puts them at risk for sure. But when it comes to the actual progression and occurrence of hypertension in pregnancy, there still is not a definitive that, like, hey, this is a disease, we know how to cure it. Basically, what we do is we identify it, we know who's at risk, we know where we see increased incidences, we monitor, and then if we see that they are progressing into some sort of a hypertensive disorder during pregnancy, we manage the symptoms. Ultimately, the only cure for hypertension in pregnancy is delivery of the baby, because it was the pregnancy that induced this vasospasm and the other things that are happening in the body. We'll talk about those in a minute or two. The other thing I do want to point out to you is that the language diagnostically surrounding hypertension in pregnancy has changed in the last decade. And it's changed significantly even over 30 years. So if you were sitting with maybe your moms, likely your grandmoms, if you were sitting with them and talking about a woman who had high blood pressure, then got really bad headaches, they might say, "Oh, she had pregnancy-induced hypertension," or even some people used to call it toxemia of pregnancy back in the day. And that we don't use that term anymore because it's not a toxic event by any stretch. And even the term pregnancy-induced hypertension, or PIH, used to be the term that we used, pregnancy-induced hypertension. Makes sense, right? Reasonable. But what we've done now is we've actually looked at through the years, as we've kind of captured this disorder of pregnancy, that really there's stages of this disorder, and some women progress through the stages and some women will not. So what we break it into is are we talking about gestational hypertension, yes or no? And if so, does the woman progress to a point in the disorder where she becomes preeclamptic, meaning we're seeing changes, renal function, maybe liver function changes, some pretty significant edema. So now it's really systemic, right? And if she is showing those signs, we call her preeclamptic. The threshold, if you will, or the apocalypse of hypertension in pregnancy is eclampsia. And eclampsia, the definition of it in and of itself, is the woman who's going through this disorder who now is seizing. And really, it's seizures. If there's eclamptic activity, she's seizing. And the seizures, the underlying cause of the seizures is the increased intracranial pressure. That's secondary to all of the things that are happening behind the scenes in her body. So those really are the three stages, if you will, of gestational hypertension. What you'll find too, that we'll talk about again in a few minutes, is that we're going to talk about HELLP syndrome. And HELLP syndrome, more often than not, is associated with women who have developed a hypertensive disorder of pregnancy. In some rare cases, women can have stable blood pressures, not present with any of those manifestations, but still develop HELLP syndrome, which means that her pregnancy, her body in response to pregnancy, is moving through this, again, sequelae, changes within the liver, which then affect her liver function, her clotting factors, and it really puts her at great risk for moving into DIC, disseminated intravascular coagulation. But that's kind of a history or an overview / history of what we understand about hypertension and pregnancy. So what you're going to find is as we move through these PowerPoints is as we identify, right? We want to identify. And what do you think the first thing we're going to identify is to medically diagnose, of course, hypertension in pregnancy? And hopefully your answer is blood pressure. And those are usually the first signs that we see. We start to see that blood pressure creeping up. As we care for this mother, we are going to continuously watch not only her blood pressure, but some of those other classic signs and symptoms that she might be progressing. Those things would be acute weight gain, more than we thought, related to likely edema. Visual changes. Is she having frequent headaches? Is she having spotty vision? Epigastric pain, which can be upper quadrant related to inflammation of the liver. Does she have urinary changes? Is she noticing that there's a change in the amounts that she voids? And when we see the client in the clinic, we will definitely be not only checking for glucose like we talked about last week, but we're also checking for protein because that's going to tell us about her liver, her renal function. And if her renal function is becoming involved, well, she could be progressing from a hypertensive state to a preeclamptic state. So we're going to look for all of those different things and then obviously her fetus, right, fetal well-being, and is she still experiencing similar fetal movement as to a day ago, a week ago, meaning that the fetus is still thriving in utero. So the assessment's going to be very specific to all those symptoms that go along with the sequelae, the phenomena of progression of a hypertensive disorder. And then again, the interventions are going to be very specific. So if it's just gestational hypertension, but it's continuing to progress, well, then we might be looking at the medical team, her team caring for her, implementing some sort of a antihypertensive medication, perhaps nifedipine, where they'll manage the blood pressure medically. Obviously, diet and rest and those things. If it's progressive, well, then we have to manage those other changes as well. In particular, if she's preeclamptic and progressing steadily towards that threshold of perhaps seizing, then magnesium sulfate would be the drug of choice. And that would basically be used to change the threshold, the seizure threshold, so to really impact the neurological changes that are occurring. Keep in mind that magnesium sulfate, number one, does not cure gestational hypertension. The purpose, the goal of magnesium sulfate is to prevent seizures. The second thing that will happen with magnesium sulfate, and we often do this in medicine and nursing, is that we monitor the blood pressure because she's gestationally hypertensive. And we could see changes and see that blood pressure come down a little bit because of while the patient's on MAG. It's likely that that's happening because she's in a very restful state. Magnesium sulfate, when given therapeutically, really does render the pregnant mother tired, lethargic. She really can't get out of bed. I mean, she's really going to feel the effects of the magnesium sulfate. And whenever we take the body and we just really, suppress it, you're going to see that blood pressure respond, and it's going to decrease. Magnesium sulfate does not cure the blood pressure problem. It simply prevents the onset of seizures. So you'll notice that on PowerPoint slide 23, that I have a chart for you that refers to the three stages: the gestational hypertension, the mild preeclampsia, and then a severe preeclampsia. And I didn't put eclampsia there because the only thing that we would add to eclampsia, right, is that she's seizing. So when we look at a client who's progressing, we want to separate them out from mild to severe. Because if she's severely preeclamptic, then she requires admission to the hospital for close monitoring and most often aggressive interventions to manage the disorder. So take note about hypertension, because there is an important concept here. In order to diagnose someone with gestational hypertension, the hypertension has to have an onset during pregnancy, meaning that their baseline blood pressures were not elevated. They had a normal range of blood pressure. It's something that we see after the 20th week, and we're going to see that blood pressure greater than 140/90 on at least 2 occasions within a week that are measured at least 4 hours apart. So anecdotally, a patient arrives to the clinic and the patient has a blood pressure of 150/92. So, of course, I know you would do this. You would say, are you relaxed? Are you in pain? A nice assessment. Make sure the client's comfortable. If she's up on an examining table, is she on her left side? All of those things to make sure that it's not really just an isolated elevation of blood pressure. We could wait an hour and recheck it, but really the right thing to do is to give her 4 hours, at least minimum, and recheck her. Sometimes in practice what we'll do is, check the blood pressure as she arrives. If it's elevated, maybe before she leaves. If it comes back down before she leaves, was she nervous? Was she anxious? Is this more of a sympathetic response to, my baby's coming, I'm getting closer to dates? But if it's still suspicious, and obviously if any other symptoms like a headache or spotty visual changes accompany that, well, then that's certainly, and the weight changes, that's certainly something that we have to pay close attention to. But we want at least 4 hours apart. We wanted to see that blood pressure over 140/90, and she's got to be in her 20th week or beyond if we're going to really tag her with a gestational hypertension diagnosis. If she's showing with hypertension early on in the pregnancy, the consideration has to be, did she always have hypertension? And that, pregnancy certainly doesn't make that better. And you remember, we're talking about young, healthy women who may or may not have had consistent health care up until their pregnancy. So, if they haven't seen a doctor in 2 years, who's to say if their blood pressure was elevated or not? So 20th week and beyond, and this develops, is pretty much classic gestational hypertension. Now, if she's just hypertensive and she hasn't progressed to any further in the disorder, that means we're not going to see any protein in her urine. And likely, if that's all she has, we're just going to monitor her. And in rare cases,